Hi there. I am Claire Postel, and I am a psychotherapist at Ohio State University Wexner Medical Center. And today I'm going to share an interesting case, sexual health case that I see with psychotherapy. So this is a case. It's interesting. It is not bizarre. It is not. It wasn't difficult. It wasn't. I forget what the other word was used. It wasn't awful. It was just interesting, and it changed the way that I assess certain sexual dysfunctions and sexual health needs. And so I thought I'd share it and kind of promoting more people to be thinking about masturbation when assessing sexual concerns. So I have no disclosures. So this is a case, and it was a couple that I saw. They were young, they were in their mid 20s. They were married for about a year and a half, and they were heterosexual. So the female partner, she had vaginismus and was in pelvic floor physical therapy, so was not able to do penetration because of pain and muscle tightening. And her partner, her male partner, had delayed ejaculation and occasional ED. So the erectile dysfunction did get worse while we were working together temporarily before it did get better. But that was kind of what we were working with. So it was kind of this everyone had something going on. So also the couple was religious. So they had waited till they were Christian. They had waited till marriage to engage in sexual activity, and so they felt super discouraged their wedding night when they go to do sexual activities and they attempt penetration, and it just didn't work. She had incredible pain, and they stopped, and he had some erectile dysfunction. They other sexual activities they did, he was not able to reach orgasm, and so it became very frustrating, and they felt so confused. This was not what they had been told about sex, and so they felt incredibly discouraged too. Um, so in kind of asking them more about kind of sexual function, they were both able to orgasm. Just they had not figured out how to do it together, and so that was really the issues that were coming up. So it probably took maybe 2 or 3 sessions before I asked about masturbation techniques. And so they're like, oh, yeah, we're able to orgasm alone. But they were like, we just can't do what we do alone with our partner. And I was like, and I kept suggesting things, and they were like, no, it just doesn't work that way. And so what I found out is that they both actually had an atypical or idiosyncratic masturbation technique that was not compatible for sexual activity with a partner. Um, so the female partner would apply pressure to like around her clitoris on something very, very hard, like concrete. And she would say this like concrete or granite, something incredibly, incredibly hard. And it wouldn't take much pressure, but she would just apply pressure and be able to orgasm. And she had done this from youth. Likewise, he had also, where he would lay on his stomach and apply pressure on his hand and be able to reach orgasm. And so, that was just not something they're like, we don't know how to incorporate this. I'm like, yeah, that makes sense. And so doing a little bit of research, there is some minimal, but there is some research about educating patients about masturbation and orgasm to make sex better, to get more pleasure from it. There is research on atypical masturbation techniques that cause erectile dysfunction in men, and so the research is out there. And so what did I do? So we started with some psychoeducation, just managing expectations for healthy sexual activity. We talked about what sexual activity can look like because they really didn't have a ton of experience. Bibliotherapy along with that, where they read books. So they read Come As You Are, and they read She Comes First and Becoming Cliterate to learn just more of what to do with other sexual activities. Partnered activities they did were sensate focused, so a lot of of touching and exploration, which they didn't love. They found it very awkward and weird, but by the end they were much more comfortable with it. They also would do individual sex, so some solo sex with masturbation training. And they also when they got to penetration, we did some coital alignment education. So I only saw this couple for about 6 months, and I saw them once every 2 weeks. I don't love seeing, like, there's like this threshold that I see people for, or between, and I don't like to see them every week, and I don't like to see them every 3 weeks. Like, 2 is kind of my sweet spot, with in terms of homework and getting stuff accomplished and avoiding procrastination. And they were hour-long sessions. So this was a successful case. They were able to do penetration. They were able to get more out of sex and enjoy it more. But the implications are that we need to kind of, as sexual health providers, be assessing technique. So I listed here the common things that we assess for, and this is what I did. I would assess for frequency. I'd assess for motivations. Why would you, like, what is motivating you to masturbate? And so it'd be like, is it desire? Is it stress relief? Is it boredom? Pornography consumption? Are you looking at pornography? What are you doing in terms of fantasy work? How is this impacting your sexual function later? And do you use any toys? But I wasn't asking, what do you do? What's your technique? And that's imperative. And so if you get anything from this presentation, hopefully you incorporate asking patients about technique, because it has really just changed the way I think about sexual dysfunction. Okay, thank you so much. Thank you.